Periodontally accelerate osteogenic orthodontics. This is a concept that was presented by the Wilco brothers, Tom and Bill Wilco, and I became aware of this in the early 1990s. It was initially presented as a technique for rapid orthodontic movement, with orthodontic cases sometimes completed in as short a time as 3 to 8 months. It's later been expanded by other presenters, and I'm thinking specifically of Colin, Richman, and Serge Debart, which have made the technique even more versatile. With the presentation by the World Workshop and the American Academy of Periodontology in 2018, I think we need to think in terms of a classification of biotype. And there's an additional PowerPoint video in this series on my web textbook that addresses that topic. In any event, I want to give total credit to the Wilco brothers for their diligent work on this over many, many years, presenting a concept that can become a standard of care in periodontal therapy and render a real service to many, many patients. Periodontally accelerated osteogenic orthodontics. Various terminologies have been used for this technique. It was initially called Wilcodontics, which was a patented term by Tom and Bill Wilco in this article that they published several years ago. So periodontally accelerated osteogenic orthodontics was a later term that they used. Also, PAPA, or pre-orthodontic periodontal augmentation, is the same technique as coined by Colin Richman, and Serge Debart has published work using the piezo knife in this same technique. Before going further, I want to give credit to these two visionary dentists, Tom Wilco on the left and Bill Wilco on the right, Tom being the periodontist and Bill being the orthodontist, for their visionary, innovative efforts in bringing this technique to the forefront of dentistry. So 2 thumbs up for the two Wilco brothers, and I certainly do appreciate their friendship over the years. The significance in the adult patients. Arches can be expanded without producing osseous dehiscencies or fenestrations, and this may prevent future recessions. This increased bone mass allows for greater tooth movement in the adult patient because we don't have the opportunity of using growth as we have in the child. And it prevents root resorption, and once the bone recorticates, there's no bone memory, and this prevents relapse. The basic premise on this is called the rapid orthodontic movement. And rapid orthodontic movement occurs following selective, superficial, and I want to emphasize superficial, decortication of the cortical bone. This is not a corticotomy. Superficial decortication. In thin bone, and interdental grooves are made, and grooves are connected apically, as we see is being done here in this case by the Wilco brothers. Superficial decortication. In thick bone, we have the same interdental grooves. The grooves are connected apically. However, we can have multiple perforations in the cortical bone, which supply additional blood supply to the bone graft material, which will later be added. And here we see in black where these little areas of decortication supplying extra bone is provided. RAP. RAP is the regional accelerated phenomenon. This is the interval following decortication before the bone recorticates. This is the same phenomenon that occurs when a bone is broken, and this typically lasts from 3 to 8 months. After 8 months, any further orthodontic movement is by regular orthodontics, and the rapid aspect has been lost. The classical surgical technique as presented by the Wilco brothers. Here we see the pre-treatment of a 42-year-old female. The diagnosis and case description. It's a class 3 occlusion, full arch crossbite, small maxilla, missing maxillary second premolars, and no previous orthodontic treatment. I'd like to emphasize there had been no previous orthodontic treatment. So here we see the arches, and we can see the crossbite on the right, and you can see the space where the premolar has been lost has been completely closed, thus creating the class 3 occlusion. And here we see a lateral view of the same thing. The case is bracketed pre-surgery. This is very important because you want to begin the orthodontic movement as soon after the surgery is done to capitalize on the 3 to 8 month period before the case recorticates. Full thickness flaps before the decortication. And here we see following decortication. And you can see the grooves here, and occasionally we can see the perforation where there is cortical bone. The osseous graft has been placed, and this is a combination of freeze-dried bone as well as bovine bone. And you will note that no membrane is used on this. So a biopsy following the interproximal of tooth number 19. And this is some time later, and you can see where the Wilco brothers have gone in, and that bone that they placed actually has healed and formed natural bone. So here we see the pre-op CBT scan and the way that it looks after the case is finished, and I think it is quite clear that we're not going to have any dehiscences or we're not going to have any future recession because of the addition of bone. So the addition of bone for preventing recessions is a key factor, although the rapid movement is something that appeals to the patient. Now, 2 weeks afterwards, we see the case is bracketed. You can see the sutures are ready to be removed, but you will see there has been no movement because nothing happens in the first month or so. So at 1 month, we have better healing, and look at the gingival health that we have, the thick biotype, which we will discuss perhaps later, and the case has had no movement. The window of opportunity. 1 month after decortication, osteopenia occurs. This osteopenia allows for the rapid orthodontic movement, or the RAP that we talked about before. In approximately 8 months, the bone begins to recorticate, remineralize, and any further orthodontic movement occurs at the pace of conventional orthodontics. This 6 to 8 month period is referred to as the window of opportunity, or WOW, for accelerated osteogenic orthodontics. Now at 2 months, you begin to see the space is beginning to open up. You see it especially with the yellow arrow. Now at 3 months, the space is even wider. At 4.5 months, it's even wider. At 5.5 months, even wider. And at 7 months, we can see that we now have on the right a class 1 occlusion, and we almost have space there to place a single tooth implant. So at 7 months, we can see the size of the space, and an implant could be placed at that particular time. So the treatment time on this case was about 9 months from start to finish. So not only do we have rapid movement on this, we also have a nice orthodontic result, and we have a thick biotype, which, as I said earlier, will perhaps prevent future recession. So here we see the pre-op view, and we see the post-op view showing the case as it finished out. So 2 thumbs up to the Wilco brothers on a very well treated case. The way the patient looked pre-op and now the way the patient looks post-op hardly looks like the same patient. Colin Richman somewhat broadened the concept. In a crowded dentition, biotype becomes critical because a thin biotype exhibits recession, type lesions, and bony dehiscences. And osseous augmentation creates a thick biotype. So here's a case of Colin showing before and the osseous augmentation that he did at time of surgery. And this inspired me to do a video on biotype classification and clinical significance, which can be found on my web textbook, which you see below. Broadening the concept. If a patient is not responding to conventional orthodontic treatment, PAOO can be initiated at any time to jumpstart the case and get it going again. It can be used in cases that have relapsed following conventional orthodontic treatment, and it has been found that if the case is retreated, that you're not going to experience further relapse because bone memory is gone and the case is much more stable. Reconstruction of the mucogingival unit. This produces osseous regeneration, and coupled with soft tissue augmentation creates a thick biotype. What is the significance in the special needs patient? Obviously, a special needs patient needs to be treated as quickly as possible so it shortens the treatment time. And by the improved orthodontic alignment, this enhances plaque removal. And in these patients, perhaps the use of a sodium hypochlorite solution in a water irrigator supervised by the caregiver, and notice that I emphasize caregiver, can markedly improve plaque removal. And we talk about a sodium hypochlorite solution, and I would refer you to the video, The Most Effective, Least Expensive Mouthwash. Technique in treating periodontally involved teeth. Here we see a 42-year-old gentleman who appears to be just fine from an aesthetic standpoint. You can note that the maxillary anterior teeth have nice alignment, and when you look at the occlusal view, you can see that the second premolars are markedly misaligned. And what you would initially think in terms of doing would be to go ahead and remove those second premolars and close that shortened space on either side. But let's wait a minute, because these teeth need to be removed because of severe periodontal defects on the mesial, with pockets ranging up to 10 millimeters in the furcation area, as well as significant calculus present. On the lower, you can see the severely tipped molar on the left, and that will be removed. And there's a video that will be on here, which later we found out that tipped lower molars can be tipped distally, and augmentation of the bone on the mesial can take place in about 3 or 4 months. And not only can that molar be saved, but also there's room for a nice implant in the first molar area. So look at the lecture, Rapid Orthodontic Movement on Uprighting Molars, which is on the web textbook as well. So the area is reflected, and what I want you to notice, there is a buccal furcation on that first molar. And we've talked about earlier videos using the MMPPI, showing that furcation involvement is not nearly as significant as we have talked about in the past. So we're not going to be overly concerned about that. On the palatal, because this is going to be moved facially, you can see that we did not elevate much of a flap just for access to get the granulation tissue out. And on the left, you can see what the probing depth is on that first premolar. And when those premolars are extracted, you can see the attachment loss, furcation involvement on those molars, and it's quite obvious why those premolars need to be removed. Here we see the grooves that were placed by my colleague, Mary Lee, and then she did place a few of the perforations to allow for more bone grafting material. And this is the bone grafting material in place, and please note that no membrane was used. So here we see the pre-op view, and at 2 months we can see how much movement we've already had, because you're going to be shifting that second premolar into an edentulous space. And at 2 months postoperatively, note the thick biotype that we have bilaterally on that. And again, that molar is going to be removed. And now we're looking at it at 2 months and 3.5 months. And at 3.5 months, the case is almost completed. And we've gotten rid of one severely involved premolar on either side. So here's a 5-year post-op, and you will see the existing crown that was present on the left on this slide and the implant on the right of this slide. And here we see the 5-year post-op showing a good occlusion, and the orthodontics in that case took very little time, but we also treated significant periodontal defects in conjunction with the ortho treatment, which was very simple to do. So the 5-year post-op, we look at the upper view occlusally, and we look at the mandibular view. And there's really very little difference change in the fascia of the patient because nothing was done with the vertical dimension and no teeth were aligned in the anterior area. So here's the pre-op view showing the severe involvement of that lower molar down there. And then we see the post-op view 5 years later with the implant in place. And you will notice that furcation involvements on that upper first molar that we showed you is still present but presents no problem. And the management of furcations using the least expensive, most effective mouthwash would certainly be indicated on that. So on this last patient, let's go ahead and score the patient using the MMPPI. And the age of the patient is 1 because he is in his 40s. He's non-smoker. He's not a diabetic. The molar type is number 1. That's that first premolar in the maxillary arch, which had the furcation involvement. The probing depth on that was about a 5. The furcation involvement was a 1. Remember that. And we did think that the tooth was mobile. And the score on that is a 5. 5 years later, we score the same case. Age remains the same. Molar type remains the same. We did have no probing depth. We still have that furcation. And the mobility is no longer there. So rather than a 5, we have a 3. So a 5 meant that he had a 93% chance of keeping the tooth for 15 years, whereas a 3, it's risen to 96%, and the case is now 5 years older. The furcation involvement is still there, but that tooth has an excellent prognosis, which reminds us we do not want to go in and remove teeth simply because they have a furcation involvement. Again, the post-op picture. And I'd like to thank Dr. Joe and Dr. Mary Catherine Gray, who was the periodontist involved in this case. The final case we're going to show was treated by my colleague Mitchell Godat, the periodontist on the left, and Bill Paris, the orthodontics on the right. This is a 59-year-old female, and you will notice the smile that we see preoperatively on the right. Now what we're going to do in this case is restore the vertical dimension. And any orthodontist will tell you that this is much more significant and difficult to do than actually doing basic orthodontic treatment. The patient has a class 2 profile, has a retrusive chin, a protrusive lower lip, a deep labial fold, and excessive chin tissue in the underneath of the chin. Now, the deep impinging overbite with collapsed arches we can see here. And the class 2 molar relation on this side, on the left, is 8 millimeters, and the class 2 cuspid relationship is 6 millimeters. And this is vertical dimension is going to be restored without doing any orthognathic surgery. So, previous extractions of the first bicuspids have been made. You can see occlusal enamel wear and the drifting of teeth. And this is the pre-op view on a Panorex, which really you can't tell a lot from. Here is a cephalometric analysis done by Dr. Parrish, and it shows a class 2 skeletal relationship. It also shows a retrusive mandible, and it also proclined mandibular incisors, and a normal maxilla, and a slight proclination of the maxillary incisors. Now let's discuss treatment options. One treatment option with that level of vertical loss would be to go ahead not only and have complete orthodontics done, but also to have orthognathic surgery, which would include the mandibular advancement. This would be very expensive, require hospital surgery, and in all probability take at least 3 years. Option 2, the treatment time would be approximately 3 years using conventional orthodontics, and I don't think you would have gotten as good a result as we're going to get with option 3, which the patient chose, which included orthodontic treatment and PAOO. And here we see the pre-op view with a significant overbite, and on the right we see the post-operative view after 20 months showing that the vertical dimension has been restored. And we can see the amount of tooth structure showing on the pre-op here and the amount here showing the significant increase in vertical dimension and restoring that. So here the patient is not smiling, and this is the way she looks 20 months later. And the patient says that people think that she's had a facelift. Does not even look like the same patient. And here she is smiling before, and here she is smiling here, and she looks much younger, and simply done an outstanding result by Drs. Godad and Dr. Paris. And let's look at the lateral view. Look at that turkey gobble underneath there, and see how much better she looks at 20 months on that. So 2 thumbs up to my colleagues, Mitch Godad, who was the periodontist on the case, as well as Bill Paris.